Good afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Professor Dr. Mohan Rajan sir. And let me share some of the achievement of sir. Sir has done MBBS, DNB in ophthalmology, DO, FMRE, MNAMS, MCH, FACS, DD, FIAMS, FRCS, PhD, DSc, and Chairman and MD of Rajan Eye Care Hospital, Chennai. And today, sir is going to speak on a topic diabetic eye disease on the occasion of Healthy Vision Month, July. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Stage is yours. You can proceed from here.
Thank you, Faraz, and thank you, Ankana, and the entire IJCP group for the wonderful opportunity. It's always a pleasure to be here and give these med talks, and I really cherish the association with the IJCP for this wonderful thing. As you all know, the diabetic eye disease is a very common issue, and diabetes mellitus is becoming a very common problem in our country. What is diabetes mellitus? It's a common metabolic disorder characterized by sustained hyperglycemia. That is, hyperglycemia means blood sugar going up of varying severity. Due to lack or diminished efficacy of endogenous insulin, there are two types, type 1 and type 2, that is, insulin dependent diabetes mellitus, and non insulin dependent diabetes mellitus. And all these have a bearing as far as the eye is concerned. Look at the staggering statistics. In 2007, we had only 26 million people who are diabetic, but by 2025, we already touched more than 100 million. India has got the largest number of diabetics in the world, which means that India is the diabetic capital of the world for many reasons, which we'll talk about it later. India is already the cataract capital of the world. India is already the largest producer of children with blindness in the world. So, the diabetic retinopathy and the diabetic neuropathy and the diabetic nephropathy. Neuropathy means affecting the nerves, nephropathy means affecting the kidney, retinopathy means affecting the back of the eye, which is called the retina. This is called the root triad, and these all go hand in glove. So, it's very important. Whenever there is a nephropathy, there will be an associated retinopathy and neuropathy as well. So, the diabetic eye disease, there are various manifestations as far as diabetic eye disease is concerned. You can have problem on the ocular surface, for example, dryness of the eye, or you can develop a more serious issue which is called cataract, or even more serious issue which is called glaucoma, eye pressure, or when there can be recurrent stye or boils in the lid, which is called stye or chalazion, a diabetic papillopathy wherein there is inflammation of the optic nerve and there is a sudden drop in the vision because of a decrease in the blood supply. And the anterior ischemic optic neuropathy is also a similar condition. So all these problems can occur like glaucoma, cataract, and these are all manifestations of diabetic eye disease. Just to show you a different, this is a patient with an endophthalmitis after the cataract surgery. And whenever you do cataract surgery in diabetics, there's a more possibility of infection. Any diabetes, the infection rate is a little high because these are all patients who don't have this immunosuppression is there. And because of that, infection rate can be seen. This is a patient with a postoperative endophthalmitis. Again, a patient with the glaucoma, wherein you can see the optic nerve. Two types of glaucoma, which is an angle closure glaucoma and open angle glaucoma. The open angle glaucoma is commonly associated with the diabetes mellitus. Though there is no direct relationship, there is an indirect relationship between diabetes and glaucoma. And of course, as I told you, diabetic papillopathy or anterior ischemic optic neuropathy is more commonly seen in hypertensives, but also can be seen in diabetics as well, wherein there is a swelling of the optic nerve, as you can see here. Again, infections of any part of the eye, for example, infection of the cornea infection, and in diabetics, you can develop what is called the fungal corneal infections. which can be very, very serious as far as the vision is concerned. Again, recurrent chalazion, and we need to come to the cataract. As you know, cataract is the most common manifestation, or the second most common after the retinopathy. The cataract is the second most common complication of diabetes mellitus on the eye, and the risk of cataract in diabetes, age of the patient, duration and severity of the retinopathy, high HbA1c, that is HbA1c means glycosylated hemoglobin, wherein there is a 3 months control is taken into account, associated with hypertension, renal disease, smoking, multiple laser treatments for proliferative diabetic retinopathy, past planar vitrectomy surgery for vitreous hemorrhage, and TRD, that is tractor retinal detachment. The pathophysiology is glucose, the aldose reductase, which goes into the sorbitol pathway, which increases the sorbitol, which retains within the lens. There's an osmotic gradient when the sugar goes up, and the lens starts swelling, and lens starts opacifying, and that is what is called cataract. The typical diabetic cataract is a posterior subcapsular cataract, or a cortical cataract, or a mixed cataract, or unique to diabetes, which is called the snowflake cataracts, as you can see in this particular picture. The surgery for cataracts, we need to stabilize the retinopathy first, and then go ahead and do the surgery. And this surgery, we can use different machines, and this is an irrigation aspiration capsular polish. But most important things, we need to put a lens in the bag. In this particular case, you can see how cataract surgery in a diabetic patient is being done. You can see the typical posterior subcapsular cataract. I'm making an opening in the front of the capsule, front of the lens, which is called the anterior capsular rhexis, and then going ahead and doing the phacoemulsification procedure, which is there, and you can see here, and then putting a lens into the bag, which is again very, very important for all of us in patients with diabetic. Hydrophobic lens is the most common, or the most, what you call, preferred lens as far as diabetics is concerned, because these hydrophobic lenses are very inert. As you know, in diabetics, we need to be very careful of the foreign body reaction and also the infection as well. This type of cataracts, the brown cataracts, are very, very common in diabetic patients. And if you do the corneal thing, there can be corneal edema, and there can be also inflammation in the eye in patients who got diabetics, which is called fibrin. There can also be fluid accumulation in the back of the eye, which is called the cystoid macular edema. For these patients, we do what is called the robotic cataract surgery for these brown cataracts and diabetics. And this is just to show you the robotic cataract surgery, which is called the Catalyst system. And this robotic cataract surgery makes your life easy. And these cataracts, very dense cataracts in diabetics, are taken care without any complication. And you can see the crystal clear corneas in the postoperative period, which is very, very important again. In diabetics, every structure of the eye, starting from the lid to the optic nerve to the orbit, can get affected and become amenable to some sort of a infection or a reaction or inflammation in the postoperative period. So now coming to the diabetic retinopathy, which is the focus of this talk. As I told you, 26 million in India in 2007. It has crossed more than 100 million in now, and is going to become close to 120 million in 2025. India has already become the diabetic capital of the world. The prevalence is 15% in the urban areas and 12% in the rural areas. The most important thing is that 20% of these diabetics, suppose we have 100 million people who got diabetes, 20%, which is about 20 million people, can develop a condition in the retina which is called diabetic retinopathy, which is a blinding disease, and they have 25 times greater risk of going blind when compared to the normal general population. So, how common is diabetic retinopathy? It is the major cause of avoidable blindness in the world and leading cause of new blindness in the working population. The prevalence of diabetic retinopathy is higher in insulin dependent or type 1 diabetes, 40%, than in non insulin dependent or type 2 diabetes, which is around 20%. Some degree of diabetic retinopathy eventually develops in all patients with diabetes. Longer the duration of the diabetes, the higher chance of diabetic retinopathy. So, no diabetic retinopathy for at least 3 to 5 years after the onset of diabetes, the duration of diabetes, more than 15 years of type 1 diabetes or insulin dependent. 50% of them developed what is called the proliferative diabetic retinopathy, which is the stage 3 and stage 4 of diabetic retinopathy. More than 20 years of type 1 diabetic mellitus. 99% can develop diabetic retinopathy. So, longer the duration, the more chances of diabetic retinopathy, especially in the type 1 of diabetes mellitus. What are the other risk factors? The common question the patient says that my blood sugars are under control, but why do I get diabetic retinopathy? It is not only the blood sugar which is necessary, but it is also the associated hypertension and the kidney functions and the taking care of the anemia, which is the hemoglobin percentage, hemoglobin, what do you call, the amount of hemoglobin in the blood. And of course, smoking, alcohol, pregnancy can aggravate. It's called gestational diabetes. Obesity is directly proportional to diabetes mellitus. Dyslipidemia, for example, if you have raised cholesterol, triglycerides, and LDL, that is called the low density cholesterol. All these can increase the what is called the incidence of diabetic retinopathy as well. So it is not only the duration of the diabetes, the control of the diabetes sugar, the type of the diabetes, whether type 1 or type 2, the associated blood pressure, the associated kidney functions, and the lipid profile, all these anemia, all these come into factor. Let us see this animation. What happens in diabetic retinopathy? As you see, the light rays get focused in the center of the retina. The center of the retina is called the macula. The center of the macula is the fovea. In diabetic retinopathy, this is the center of the retina. In diabetic retinopathy, what is happening is small hemorrhages or bleeding starts occurring in and around the center of the retina, which is called the macular area. And gradually, these microaneurysms, they start bleeding and become retinal hemorrhages, and they start what you call the water starts accumulating into the retina, and lipid deposits also occur, which are called the hard exudates, and the water in the retina, which is called the macular edema, and all these can lead to the drop in the vision as well. And as the diabetic retinopathy progresses, you can see here new vessels. These new vessels are forming, and this is part of the proliferative diabetic retinopathy. The new vessels are forming mainly because the new vessels, there is a lack of oxygen because lacks of blood supply to the retina, which occurs in diabetic retinopathy. Similar to the hypoxia, which we used to get in COVID, the same thing, the hypoxia of the retina stimulates the new blood vessels, and these new blood vessels start bleeding into the eye, producing vitreous hemorrhage and drop in the vision. Pathogenesis of diabetic retinopathy: it is an ischemic microangiopathy and thickening of the basement membrane, loss of microvascular pericytes, breakdown of the blood retinal barrier. What happens is because of the persistent hyperglycemia, there is lot of pericytes, or what you call the lining inside the blood vessels. The hypoxia, the reduced oxygen supply to the retina, leads to damaged endothelium. Endothelium means the inner lining of the blood vessels, the arteries and the veins of the retina. And when the damage, it starts leaking. That's called hyperpermeability, and that is causing the breakdown of the blood retinal barrier. There is a barrier between the blood and the retina, and the barrier gets broken down in diabetic retinopathy, and you can get exudates, microaneurysms, and macular edema. All these as a result of that. A further progression of the diabetic retinopathy, the retinal hypoxia, as I told you, the angiogenesis, new vessels start forming, and you can have new vessels on the optic disc, which is called NVD, or new vessels elsewhere in the retina, which is called NVE, or the new vessels on the iris, which is in the front of the eye, or the shutter of the eye, which is called rubeosus iridis. And these can be very, very problematic and can produce serious loss of vision as well. So basically, we have the stage 1 of diabetic retinopathy, which is called the background diabetic retinopathy originally, or non-proliferative or non-proliferative diabetic retinopathy. And you have microaneurysms, hard X-rays, retinal edema, retinal hemorrhages, and then you can see all these start developing right in the beginning, in and around the center of the retina, wherein they're similar to the this thing, wherein there's a beginning of the vessel wall, and it's in the level inner retina. The retina consists of two layers, the inner retina and the outer retina. The inner retina is the most commonly affected in diabetic retinopathy. And you can see here how the blood is leaking when you do the fluorescent angiogram for these patients. These hemorrhages can see the red spots on the retina, which is the bleeding on the retina. The yellow spots are the hard exudates on the retina. Flame hemorrhages, the superficial hemorrhages, there are deeper hemorrhages in the retina, and all these can cause problems in the vision as well. And these deposits of lipid material, that is called the hard exudates, can also produce significant drop in the vision, because these deposits usually occur in the center of the retina, which is called the macular area, and that is called the clinically significant macular edema. Then the next stage will be the background and the pre-proliferative diabetic retinopathy, the stage 2 of diabetic retinopathy, wherein you can have cotton wool spots, intraretinal microvascular abnormalities, venous changes, arterial changes, and dark blot hemorrhages as well. These cotton wool spots can also occur, very typical of diabetic retinopathy, can also occur very typical of hypertensive retinopathy as well. So these shunt vessels from the arterioles to the venules that bypass the capillary bed adjacent to the CNP areas resemble the flat NVE. Venous abnormalities can also occur. Then we have the stage 3 diabetic retinopathy, which is called the proliferative diabetic retinopathy. New vessels, as I told you, can form on the disc, that is the optic nerve, or elsewhere in the retina. And new vessels are very fragile, and they start bleeding now and then, and produce this thing called vitreous hemorrhage or pre-retinal hemorrhage, which can be either intragel hemorrhage or in the hemorrhage inside the vitreous cavity. And that can cause significant drop in the vision. And all of a sudden, patients come to you with a sudden drop in the vision because of vitreous hemorrhage. And many of them may require surgeries called vitrectomy to clear them up as well. Then the new vessels are the hallmark of the proliferative diabetic retinopathy or the stage 3 diabetic retinopathy. So the new vessels can be on the either posterior, that is the posterior means closer to the center of the retina, or also very rarely in the anterior, that is in the periphery of the retina as well. These are all the new vessels on the optic nerve, and these new vessels on the optic nerve can start bleeding when the patient coughs or has a violent bout of sneezing, or when he lifts heavy weight. So the patient can sing. Unfortunately, many patients come to you at stage 3, wherein they don't even know they are diabetics. And when we check the blood sugar, when you see the eye and then check the blood sugar will be in the range of 350, 400. And then only they know diabetes. Because diabetes can be a very serious problem. And up till stage 3, you can have fairly good vision. And that's the reason why it's important that as soon as you are diagnosed with diabetes, or if you have a family history of diabetes, please check your diabetes and come to an ophthalmologist for a checkup. Don't go to an optical shop or an optometrist because they will check the vision and they will say your vision is good and they will send you off. But your ophthalmologist, if you come, an eye doctor, what happens is they'll dilate and have a look at the retina and they can find out because stage 1, if you find out diabetic retinopathy with the control, strict control of your diabetes, hypertension, cholesterol, the kidney functions, and other anemia, you can even reverse the stage 1. But beyond stage 2 and 3, we need to give some form of treatment, either in the form of a laser or if there is macular edema, injections into the eye. So, advanced diabetic eye disease, that is called the advanced diabetic eye disease, or stage 4 of diabetic retinopathy. You can see here the vitreous hemorrhage, the hemorrhage bleeding inside the eye, and also there is a fibrovascular proliferation which starts pulling the retina up. That is called the retinal detachment or tractional retinal detachment, very typical of diabetic retinopathy, which is called the tabletop retinal detachment, which can occur. You can see in these pictures. In this one, the patients usually require surgery. That is called the stage 4 or advanced diabetic eye disease. And the prognosis, even after surgery, for getting back good vision is not very good. So this is the different stages of proliferative diabetic retinopathy. You can see the stage 3 on top, then gradually the bleeding increasing and producing fibrovascular tissue and fibrovascular proliferation, which causes detachment of the retina and significant drop in the vision as well. As I told you, when there is a problem of ischemia or hypoxia, hypoxia means reduced oxygen, ischemia means reduced blood supply. When there is reduced blood supply, there is reduced oxygen. So ischemia can lead to hypoxia, and hypoxia can lead to new vessel formation, not only in the retina but also on the surface of the iris, which is the front part of the eye as well. So, the EDTRS early treatment diabetic retinopathy study classification is a slightly different. NPDR, the non-proliferative diabetic retinopathy, mild, moderate, severe, and very severe. Proliferative diabetic retinopathy, I showed some pictures as well. Early, high risk also. This is the mild NPDR. The problem with this thing is only one microaneurysm is seen, but hemorrhages or microaneurysm both are less than the standard 2A photograph. The risk of progression to proliferative diabetic retinopathy or stage 3 in 1 year is about 5% and 15% at the age of at 5 years. So normally when you diagnose diabetes mellitus, so within 5 years, you start normally, if at all 5 years, you will get the diabetic retinopathy if there are changes in the retina. So you need to make sure that as soon as you are diagnosed with diabetes, or even before that, I would suggest that you check your blood sugar on a regular basis and blood sugar and go to an ophthalmologist even if you don't have a problem and have a checkup, yearly checkup, so that they can dilate your eyes and have a look at the retina. So moderate NPDR, you can see that hemorrhages, microaneurysms, venous bleeding, soft X-rays, intraretinal microvascular abnormalities. The risk of progression to stage 3 of proliferative diabetic retinopathy is 27% at 1 year and 33% at 5 years. So the severe NPDR is 4-2-1 rule. So any of the depending on the four quadrants, and all the four quadrants get affected. Four quadrants of the retina. It's called the 4-2-1 rule. Intraretinal hemorrhages, four quadrants. more than two, that is two quadrants, is venous bleeding and severe intraretinal microvascular abnormalities in one quadrant. 52% risk of progression to proliferative diabetic retinopathy. Already they are in almost the end of stage 2 and they become stage 3 very fast, almost 52%, and 60% progression at 5 years. So all these, if you don't treat and leave it like that, but if you treat, there's a good chance that many of the problems of diabetic retinopathy can get sorted out to a large extent. So high risk PDR, you can see that, as I told you, retinal detachment, hemorrhage inside the eye, the traction retinal detachment, and the most important thing is the diabetic maculopathy, where in the center of the eye, which is called the macula, can get affected in diabetic retinopathy, and water or fluid can get accumulated in the center of the retina, which is called the macular edema, which can cause significant drop in the vision. So, for these patients, we make sure that the systemic factors, whatever we do in diabetic retinopathy or any diabetic eye disease for the matter, the first core thing is the taking care of the systemic, because the systemic diabetes mellitus and the hypertension and the other factors are the primary cause, and whatever we see in the eye is secondary. So we need to make sure that the primary problem is taken care very well in these patients. Unless you take care of the primary problem, there's no point in treating the secondary problem. So these are the different types of maculopathy: focal maculopathy, exudative maculopathy, mixed maculopathy, diffuse maculopathy. And this is the clinically significant macular edema, which is again classified on the EDTRS classification. You can see how this patient on the OCT scan, there is a swelling of the inner retina, and because of the inner retina is swollen up, and this is causing massive macular edema, and the patient has got significant drop in the vision. Again, you can see the picture on the left side. On the right side is the angiogram picture. Angiogram is a thing wherein we give a dye in the vein and take serial photographs of the retina. That is called the fundus fluorescent angiogram, which is a commonly performed procedure, diagnostic procedure for patients who got diabetic retinopathy, to find out and classify them which stage they are, whether it's in stage 2 or early stage 2 or stage 1 or early stage 2 or 3 or 4. So all these things are very, very important for all of us to know exactly what exactly is happening. The center of the retina, as I told you, can get swollen up in patients who got diabetes mellitus, and this is called the cystoid macular edema. And this cystoid macular edema can be associated with subretinal fluid as well. Again, the uh, the most important thing is the fluorescent angiogram, as I told you, for documentation to identify treatable lesions in the clinically significant macular edema, evaluate the visual loss and macular ischemia, extent of capillary non-perfusion areas, differentiate new vessels from the IRMA to monitor treatment in the PDR. The treatment of diabetic retinopathy, NPDR, as I told you, on the non-proliferative diabetic retinopathy, and the PDR in the diabetic maculopathy, wherein there is a macular edema in the center of the retina as well. So, regular vision screening, intensive control of blood glucose, blood pressure, nephropathy, and serum lipid levels. Follow-up depends on the severity of the NPDR. Laser and severe NPDR in selected cases were unable to come for follow-up and loss of vision in the other eye. So, management of the metabolic control is very important, because unless you control the primary problem, and the target HbA1c should be less than 7% in these patients. Again, very important for all of us to understand that DR management and hypertension. So many people think that only control of diabetes, if they control the diabetes and they don't have control of hypertension, then the diabetic retinopathy can worsen to a large extent. So the hypertension is also very important. If the hypertension is not controlled, there can be more progression, rapid progression of diabetic retinopathy, more severe levels of diabetic retinopathy. Diffuse macular edema are more common. Control of hypertension slows progression of diabetic retinopathy. Lowering diastolic BP in normotensive patients delays progression of diabetic retinopathy, nephropathy, lowers the incidence of stroke in all these patients. So control of lipid levels decreases the cardiovascular risk, control of the macular edema, progression of the diabetic retinopathy, and all these, the lipid levels means we are talking about the HDL, LDL, the cholesterol, triglycerides, and all these are very, very important for us to know. Anemia. Why anemia needs to be controlled? Because in patients who got anemia, the blood supply to the retina becomes less. That again, I told you, ischemia, the ischemia leading to hypoxia, and hypoxia leading to worsening of the diabetic retinopathy. End stage renal disease may worsen retinopathy. As I told you, the root triad, retinopathy, neuropathy, and nephropathy, are go together. Close monitoring for worsening of retinopathy and vice versa is very important. So this is a thing wherein we do the laser photocoagulation and or the vitrectomy for patients who got peripheral diabetic retinopathy, stage 3 and stage 4 of diabetic retinopathy. Fill-in laser photocoagulation, and these are the different types of laser. We use the green laser, we use the yellow laser. The green laser is a 532 nanometers laser. The yellow laser is a multi-spot laser which we use, and because of the subthreshold, we're able to manage, and because it gives multiple spots, like what you can see here, the laser makes the life very easy for us. And you can see here again a patient undergoing a laser treatment. This laser treatment, wherein we make the patient sit down on a machine called the slit lamp biomicroscope, and the contact lens is put on the eye, and the laser is delivered into the retina. The laser takes care of the areas which are bleeding, areas which are leaking blood, leaking water or fluid into the retina as well. So again, focal maculopathy, the focal laser, the diffuse laser, all these can occur. So, but the most important treatment which has now become is the injecting anti-VEGF injections, vascular endothelial growth factors, anti-vascular endothelial growth factors. And these have been implicated as far as the diabetic retinopathy and diabetic macular edema is concerned. So all these things we need to give monthly injections. We have to give them. We'll talk about it a little later. So after PRP, that is the pan-retinal photocoagulation, wherein the entire retina gets ablated. Why do we need to ablate the retina? We convert these areas of hypoxia, wherein they reduce oxygen, into scars or anoxic scars. And because of that, it doesn't have any stimulation for the new vessel formation. If you leave it like that without treating laser, without giving the laser, as I told you, the hypoxia can stimulate new vessel formation. The new vessels are very fragile and start bleeding into the eye. The new vessels can start pulling the retina, which is called the traction retinal detachment, and cause significant drop in the vision as well. Just to show you a few cases of vitrectomy, we make very, very small holes into the eye and go into the eye, and which is called 23 gauge and 25 gauge vitrectomy. And you can, in this particular case, you can see here, it's called the 3-port pars plana vitrectomy, wherein you can go in and remove the bleeding. And what you can see, the whitish tissue is nothing but the fibrovascular perforation on the retina, and why the red ones are the vitreous hemorrhage, which is getting cleared by all this vitrectomy. These are all small cutters, and these cutters go in and cut the vitreous hemorrhage, and cut the vitreous jelly, and cut the hemorrhage, and then wherever the retina is detached, we remove the what you call the traction on the retina, and the retina automatically settles down. And sometimes, in some cases, we need to put silicone oil for long-term tamponade as well. So posterior hyaloid, wherein the retina gets pulled up. That's called the TPHF, and you can see how the after vitrectomy everything is gone. So again, for newer therapies, this has started about 15, 20, 18 years back, wherein we give injections intravitreally into the eye, patients with macular edema, and these are all the either anti-VEGFs or the steroids into the eye, and the antioxidants can also be given, but normally intravitreal we give the anti-VEGFs. There were several anti-VEGFs which are available, which is called the Avastin, Lucentis, or the Pegenex, the Eylea. So all these are very very important. The only thing is, many of these patients they have to keep on injecting every 4 weeks to 6 weeks, and of course the most important, I don't have to undermine the emphasize the importance of the primary control of the primary systemic factors like the diabetes, hypertension, and the cholesterol and lipid levels and kidney functions as well. Just to show you one macular edema, you can see on the top picture, and after one injection of Avastin, which is an anti-vascular endothelial growth factor, and how from the swelling of 540 microns, it has come to normal, and the patient's also vision also improved. Again, another patient who had injection, and patient's vision improved. So recommended follow-up schedule: mild NPDR every 9 months, moderate NPDR every 6 months, severe NPDR every 4 months. With clinically significant macular edema, we see them almost every 1 or 2 months. Proliferative diabetic retinopathy every 2 to 3 months. Very important. Focal maculopathy screening is also very important, and the screening is very important because now we have got a lot of outreach programs. These outreach programs, we have got mobile, what do you call, they call the fundus cameras, and I'm going to show you one. The diabetic clinics, the optical, the shops, non-mydriatic cameras. Without dilating, we can get a photograph of the retina. You can see in the rural hospital how the fundus image is taken by a technician, and the images are sent by the teleophthalmology to the central base hospital. From the base hospital, ophthalmologist looks at the monitor and tells whether this patient has got which stage of diabetic retinopathy. Nowadays, we are incorporating what is called the artificial intelligence, and this is just to show you the vision centers. As you know, we have started through the Rotary lot of orange vision centers, and these orange vision centers we have got the fundus camera, and we can even take a camera photograph of the fundus through the slit lamp biomicroscope, a simple fundus camera for screening, and automatically they can send the images to the main hospital where an ophthalmologist will be able to. So the biggest problem in our country is the huge volume of diabetes mellitus patients, close to 100 million people we need to screen. The problem is we don't have personnel, lack of quality manpower. So ophthalmologists are only about 35,000, 40,000, and we can't screen all the 100 million. So we have empowered the technicians, the optometrists, and we have got the latest technology based on the artificial intelligence, which is very, very important for all of us to make sure that there's no problem. Seeing. The role of Rajanayakar Hospital: all the family members of diabetic patients are examined thoroughly. All diabetic patients with or without retinopathy fundus photo for documentation is taken. Continuing medical education program for diabetes in general practitioners, general population, just to create awareness among the people that diabetic retinopathy needs to be seen, can be prevented, can be avoided to a large extent by controlling the systemic factors, and they need to come for a regular checkup to an ophthalmologist. We also have a project Netra Vahana. As you know, this project Netra Vahana is a van which is equipped with the latest equipment. It's also got a green laser, the fundus camera, the retinal camera, and this van goes from one village to another. Just to show you another patient. This is again how we are using the artificial intelligence. This is called the Rajan Rotary Right to Sight, which we launched last year. That is on the October in October. on the World Sight Day. On the World Sight Day, we launched this, wherein this is nothing but a mobile fundus camera which can be handled, which we take inside the slums, inside all the villages, and because and once we take that, the images are taken from that. We also check the blood sugar for these patients. We also check the BP. So this mobile has got an offline. You don't have to have an internet connection. Offline artificial intelligence app for finding out the stage of the diabetic retinopathy and whether the patient has got glaucoma also, but seeing the optic nerve. By seeing the retina, it will diagnose diabetic retinopathy. By seeing the optic nerve, it will find out whether the patient has got glaucoma also. So, monitoring the blood pressure in the rural setting, inside the what do you call the dense slums which are there in and around Chennai, and just taking a photograph of the retina, and we don't even have to dilate the pupil to take a photograph, and we just take a photograph, and automatically it uses an app which is there on the remedy of fundus camera, and we give information to the patients about the importance of control of diabetes, the importance of checkup with the diabetologist as well as with an ophthalmologist on a regular basis, even if they don't have any problem with the vision. So again, this app, as you can see here, the app automatically goes into the images go into this app, and the app says whether this patient has got diabetic retinopathy. If it's got diabetic retinopathy, what is the stage of the diabetic retinopathy? Using artificial intelligence, and this is called the AI powered fundus on the phone. And because of that, we're able to screen a lot of people. A lot of technicians are being trained in this particular thing. So, ladies and gentlemen, diabetes mellitus is a very serious problem. Don't take it lightly. And India is becoming the hub of diabetes mellitus in the entire country. Several factors. One is whether we are genetically prone for diabetes mellitus, number one, whether our lifestyle changes are responsible, whether our food habits are responsible, and the lack of exercise and other things are also responsible. It's multifactorial, and that's the reason from 26 million it has gone to more than 100 million today. Progression of diabetic retinopathy may be symptom free until severe visual loss occurs, and this is the need for awareness among the people that you need to come for a checkup after the age of 25 or 30 on a regular basis to the ophthalmologist. Sight threatening event is a prognostic marker for light threatening event. So, for example, if the patient has got advanced diabetic retinopathy or any form of diabetic retinopathy, it means that this diabetic retinopathy can be an indicator of the generalized of the blood vessels in the body. For example, blood vessels in the heart muscle, or the blood vessels in the kidney, or the blood vessels in the brain, or elsewhere in the body as well. Without treatment, vision loss often progresses. Timely treatment can arrest visual loss to a great extent. Diabetic patients take home message: strict control of diabetes, early referral to the ophthalmologist, regular eye checkup, monitor other systemic parameters like hypertension, kidney functions, and hyperlipidemia. Time bombs, diabetes mellitus, HIV, AIDS, and heart attacks. We have to be beware of this. Once again, I would like to thank IJCP and the MedTalks for this wonderful opportunity and the patient attention. Thank you very much.
Thank you so much, sir, for taking out your precious time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice also. So we have received some questions, sir. With all your permission, shall we take these questions?
Yeah,
The first question is from Dr. Anshuman, and he's asking what are the key pathophysiological changes that occurs in the retina of a patient with diabetes.
1 minute. I'm not able to see you. How do I see you?
Sir, you open Chrome browser, sir, then you will be able to
Chrome
see.
browser. Chrome browser. Okay. 1 minute. Yes. Okay, fine. Faraz. Thank you very
Yes,
much,
sir.
Faraz. Now tell me.
Welcome, sir. We will repeat the question once again.
Yes,
The
yes.
first question is from Dr. Anshuman. He is asking what are the key pathophysiological changes that occurs in the retina of a patient with diabetes?
The key as I told you, pathophysiology, uh, this thing, there is loss of endothelium. Endothelium is the inner coating of what you call the pericytes, the inner coating of the retinal small vessels in the retina, the arterioles and the venules, which is the capillaries. The inner coating is lost. And there, because of the inner coating is lost, there is a breakdown in the blood retinal barrier, and because all these occur because of the persistent hyperglycemia. All these can cause the problem damage to the inner coating of the blood vessel. The inner coating of the blood vessel is very necessary. It's like a pipe, okay, water pipe. If the pipe is not very good, it starts leaking. If there are holes in the pipe, the water will come out and flood the area. Similar to that, there are these pipes are very tight controlled pipes. So the cells are very tightly packed. So what happens in diabetes mellitus, especially when you have long duration of diabetes mellitus, more than 10 years or 15 years, microangiopathy occurs. Microangiopathy occurs, and these tight junctions become very loose, and they start leaking the fluid, that is water, into the retina. And sometimes they start leaking the blood also into the retina, outside the blood vessel.
Thank you so much, sir, for sharing your expertise on this question. Moving forward, we have another question from Dr. Subramanian. He's asking, sir, how should diabetic eye disease be managed in patients with comorbid condition like hypertension and hyperlipidemia?
Can you just repeat that question for us?
Let me repeat, sir. The question is, how should diabetic eye disease be managed in patients with comorbid condition like hypertension and hyperlipidemia?
Absolutely. I think it's a very important factor because once we have a diabetic eye disease or diabetic retinopathy, immediately we work in conjunction with the physician, the diabetologist. So everybody thinks, as I told you, the patient thinks that once you control the diabetes, everything becomes all right. It is not like that. Okay? Blood sugar control is very important. The HbA1c, which is a 3 months control, is also very important. But the associated hypertension, comorbid conditions, the hypertension, the kidney functions, the dyslipidemia, all these are very important. It has to be a concerted effort. For example, the patient will have a cardiologist, will have a nephrologist, a diabetologist, and a physician. So all of us, we work in unison. So if we work in unison, then we'll be able to arrive at a proper, what you call, solution to the patient, which is very very important, because otherwise we keep on treating the eye, and there is no connection between the ophthalmologist and the physician and the treating physician. What happens is the entire the treatment water we give goes down the drain. So absolutely, it will not be a this thing at all. So there has to be a two-way communication, and that is where I think we try to emphasize this point very well and tell the importance of a thing. So whenever we always talk to the physician, we can consult the physician, and we even have a conference call with the patient to make sure that whatever we are doing is to the best interest of the patient.
Thank you so much, sir, once again for answering this question, sir. We will be taking one last question from Dr. Agarwal, and he is asking what are the some emerging therapies or technologies that show promise in treatment or prevention of diabetic eye disease.
Can you repeat the question again?
Yes, so the question is, sir, what are the some emerging therapies or technologies that show promise in treatment or prevention of diabetic eye disease?
The most important thing is the injections into the eye. the injections into the eye, of course, we can't prevent diabetic eye disease, but we can prevent diabetes. So, what is the reversal of diabetes is a new trend which is coming among all the diabetologists and physicians. Once you are able to reverse the diabetes or prevent diabetes, how do you prevent diabetes? When you have a family history of diabetes, for example, your father or mother has got diabetes, there is more chances for you to have diabetes. So you need to change your lifestyle, you need to change your food habits, you need to exercise, you need to do some more walking. So you need to play some sports to make sure that you are fit to prevent the diabetes from coming, and reduce your sugar intake or the carbohydrate intake. So all this is prevention of diabetes, and reversal of diabetes is something which is also coming up in a very big way. So they found out that the reversal of diabetes to a large extent can be done by reducing your weight, by intermittent fasting, and all these things can reverse the diabetes to a large extent. Once we reduce or reverse the diabetes or prevent diabetes, automatically we can prevent diabetic eye disease. But once you get the diabetic eye disease, the new trends which are coming up is the injections, as I told you, into the eye. Before we used to do laser for all these patients, but the problem is the laser is a destructive procedure. And for injections, for example, patient has got macular edema. Once we give the injections every 4 to 6 weeks, the macular edema comes down, and the vision also improves to a large extent. So these are the emerging technologies. Future gene therapies are going to come into play, and the pancreatic transplants have also come into play to prevent to produce more insulin, and that is going to prevent diabetes. The future is very bright, but more importantly, I think we are starting right in front of us. We are having a huge problem of burden of diabetes mellitus, and once we have diabetes mellitus, please understand, all other problems are also going to increase. It's not only the diabetic eye disease, but the kidney disease will go up, the neuropathy will go up, the heart attacks will go up, the liver disease will go up. So the generalized, what do you call, the infections in the body can go up. So it's all hovering around diabetes. So it's very important that we prevent diabetes by changing your lifestyle, having less stress. One of the major problems why younger people are getting diabetes now is because of the stress factor. They are all very stressed up, either because of the domestic stress or the professional stress, and because of that, it's become a rat race for them, and they're not able to cope up. And because of that, the stress is, because of the stress, they develop diabetes mellitus. The blood sugar goes up, and when the blood sugar goes up, when it's not under control, and all the problems can occur.
Thank you so much, sir. You have explained really well, sir. And I hope that it will be very much helpful to all the audience, sir, who have joined this session, sir. And the knowledge you shared was really much practical. I hope, sir, it will be benefits to all the audience who have joined this session, sir. Sir, as I can see, sir, there is no more question. With all your permission, shall we conclude this session for today?
Yes, sir. Before that, I would like to thank Faras for beautifully moderating this session, and of course, Ankana and the entire IJCP group. And it's always a pleasure to be here, and so that the expertise and the knowledge goes to everybody. That is the idea
Thank you
of
so
this.
much, sir. It's all honors is yours, sir. We would like to see you in future also with different topic. Till then, take care of yourself, sir. Have a great
Thank
day,
you.
sir. Thank you.
Jai Hind.
Jai Hind, sir.